What makes one drug cost tens of thousands of dollars versus another drug that costs 13 cents?
You ask a different person that same question, you're probably going to get 50 different answers on it. They're still paying their own affiliated pharmacies at a much higher rate. And in some cases, I know with our state's audits, upwards of at times 16,000% more.
That is astounding. Welcome to the Litson Podcast Studios, home of the RxLaw Group. My name is Matt Gibbs. I'm a healthcare regulatory attorney here at Litson. I'm honored today to be joined by Dr. Anthony Pudlo. Dr. Pudlo comes to us from the Tennessee Pharmacists Association. Coming up on a decade now?
Oh, no, 5 years.
Okay, halfway.
5 years. Whew.
Sorry.
It feels that way.
Yeah, I bet. I bet. Well, as we get into the discussion here, you probably aged a couple of years this past session alone. Tell us, for the uninitiated, What is the Tennessee Pharmacy Association?
Yeah, the Tennessee Pharmacy Association, or Tennessee Pharmacists Association, excuse me, I'll say it right. Tennessee Pharmacists Association, we're a membership-based professional society that represents the practice of pharmacy in the state. So we're not necessarily a trade organization, and the fact that our members are not pharmacies and hospitals and other places that you'll have a licensed pharmacy, but our members are individual pharmacists, pharmacy technicians, and students of the profession.
What's the mission? What do you do?
Kind of plain and simple, we're here to advocate for the practice of pharmacy. So we help advance the practice of pharmacists as well as protect the role that pharmacists play in the way that they take care of their patients every day. And I think what's probably unique to even our membership is that we represent pharmacists and pharmacy technicians across the spectrum of care. So in some states, they might be organized where they just represent health system practice or independent pharmacy ownership only. We represent pharmacy across that whole spectrum.
What is a PBM? What is its role? And we're going to build up to what happened in this legislative session.
A PBM, or Pharmacy Benefits Manager, they pretty simply, I would say, they are a third-party entity that many times are contracted by a health insurance company to simply manage that pharmacy benefit, help that insurance company have connections with a network of pharmacies across the state, across the country, manage the reimbursement side and making sure that pharmacies can be paid timely and that it's a paid claim, if you will. In some cases, they'll also help establish a preferred drug list for that employer or that insurance company. Sometimes that's managed by the insurance company itself. But in the end, they're also trying to help utilize those medications. So they'll have proper utilization review techniques. I think a lot of providers might be, and patients will be familiar with more the prior authorization process. That tends to be one of those types of tools that a PBM will use to basically ensure that the utilization of that product is being used properly. So that, in a nutshell, is some of the many things that they do. What we've seen over the last several years is maybe an overzealous amount of influence that the PBMs have had in the marketplace. Some of that has been due to the fact that they've been a very unregulated industry for the longest time. And I do think legislators and policymakers are waking up to that, whether it's at the state or national level. But also, we've also seen PBMs start becoming owned or owning insurance companies or owning their own pharmacies, owning their own manufacturers, even a lot of different integration vertically in the system. If you want to think about the proliferation of advanced medicine, and when we saw Medicare come to market, now not necessarily that Medicare had a prescription drug benefit right away, but when we started seeing that there was accessible use of medications in the healthcare system, not just your standard penicillin out there, but when we started seeing an evolution of more product, there was a need to start processing claims in a timely manner. And I would say that's when, probably in the late 70s, early 80s, when we started seeing there had to be a better way to properly, in a timely manner, process claims. And that was really where the impetus for PBMs came in. They were developed as a claims processor when you had groups of pharmacies out there in the country, and really instead of doing a paper billing process that we many times had in other areas of healthcare, we wanted to look at utilizing technology better, and that was a solution that was being brought forward by the PBM industry.
So now you have the birth of this kind of an entity that doesn't necessarily deliver your healthcare, but is very much touching it.
Very much so. Very much so. Just going to speak to what we've seen at the state level, given some of the authorities that our Department of Commerce and Insurance has to audit PBMs. So they further saw the same level of overreach, if you will. One tactic that we've seen is a tactic called spread pricing. So simply, if you want to say a product costs $100 for that pharmacy to purchase, there's a spread there in terms of the PBM will say, okay, it's $100 for the pharmacy to buy it. We're going to charge the employer $200. Okay, and we're only going to reimburse that pharmacy maybe $125 for that product. So they made $25 off of dispensing. That'd be great. But that spread of charging the employer one thing, paying the pharmacy another thing, that difference has become overwhelming. And in many cases, we would say that product or that spread should be shared back to the employer or even shared to the patient. But in this case, we are seeing in some case examples in the state of Tennessee that some of the PBMs are seeing millions, multiple millions of dollars. Their tactic that we've started seeing as PBMs have started owning their own pharmacies, whether it's their own mail order pharmacies, their own community-based pharmacies, their own specialty pharmacies. They're also seeing in some of the data that those PBMs are paying those own pharmacies at a higher rate than other pharmacies that are in the same network and agree to the same terms, but they're still paying their own affiliated pharmacies at a much higher rate. And in some cases, I know with our state's audits, upwards of at times 16,000% more that they're paying their own pharmacies.
That's astounding.
Yeah, you can say that.
That is astounding. Not a lot of transparency into spreads and where the money's going. If I wanted to follow the money, it's going to be very difficult.
Very much so, and I think that's also a whole nother can of worms that we can talk about is PBMs also will say that they will help negotiate a much better deal on a drug cost, and some of this gets into rebate pricing, which is also a very opaque pricing that nobody knows exactly how much rebate is being shared back from a manufacturer to a PBM. And that relationship, I know there's a lot of finger pointing back and forth as well. But at the same time, I think this rebate model is becoming problematic and being a problem in the industry when it seems like the rich keep getting richer, and none of those savings are being shared back either to an employer or to the patient. Now you got a pharmacy that if they're staying open, they've cut their hours back, they're not 24 hours anymore, and the amount of service, the service provided is being diminished.
Yeah.
So it is, I think, an alarming issue that it's not new. It's been happening. I think there's a lot more independent pharmacies that have been preaching this for so long because they've seen these contracts. Maybe some of our chain pharmacies have seen some of them in little bits and pieces, but it's becoming even more glaring, even to our large national chains as well, that the contracts are just not fair.
The sad reality is, if I don't take the contract, what happens to me?
If you don't take the contract, you're not going to be able to serve those patients. And so, I think that's the struggle for a lot of pharmacies. They want to serve the members and the patients of their community, but if they get a contract from that PBM that basically they're going to be losing money on, they're at loss. Like, they don't know what to do. So I think pharmacies keep trying to be entrepreneurs and try to think differently about providing other kind of services, whether it's durable medical equipment or diabetes education, vaccinations, point of care testing. They're trying to be a resource partly to find revenue, but at the same time they're like, we can't do all of this when we still have a core function to still do for our communities, and that's making sure they have appropriate access to their medications.
simple question, very few words, extremely complex answer, stipulated. What drives drug cost?
Oh, that is a great question, and I think if you ask, a different person that same question, you're probably going to get 50 different answers on that question. I do think we do have, manufacturer will obviously lay out all the different things that go into manufacturing a product, whether it's just the raw materials, whether it's the research and development piece of it, to some regard, I guess, marketing as well. But then there's just the distribution process, right? Every stage in the process of getting product from raw material, from wherever it's coming from, into a form that can be ingested or injected by a patient at the front line. There's a level in that whole process that everybody plays a role. So there has to be some level of financing throughout that process. So that's kind of my roundabout way of saying I think there's different aspects in the entire medicine supply chain that add to the ultimate cost of a medication.
What makes one drug cost tens of thousands of dollars versus another drug that costs 13 cents?
Yeah. Some of it is the research and development side of it, right? I mean, these manufacturers spend years, and rightfully so, to make sure that we're having safe and effective use of medicines, and hence why the FDA has all their clinical trial processes. So there are some that's that. Some of them have some very novel chemical compounds, right? I mean, you look at some of the newer specialty biosimilars that are specialty products that are out there that are doing some very complex things in our body to help cure disease in some situations. That's not a simple thing as some very simplistic molecules that might be from some of our early medications. But products that have been out there on the market for a while, once they go off patent from that process, then you have multiple drug manufacturers making them, right? Now, I do think that's also where we've seen some problems in the industry, is that we're seeing less generic manufacturers making that same product. So what usually may have been multiple manufacturers making that generic product, you may only have 2 or 3 generic manufacturers now too, and that's been a bigger issue. I know that's been discussed federally as well. What kind of incentives can we ensure more generic manufacturers continue to make these products? But when you have that market scale, that'll help keep some of those prices lower as well, especially when those, like I said, when those products come off a patent.
Let's fast forward to December, January, February of December 25, January, February of this year. Tennessee General Assembly gavels in.
Yeah.
There's a bill introduced in the Tennessee General Assembly that would, and my phrasing, would ask a PBM to either own your PBM or own your pharmacy, but you can't do both.
It's Bill 2040, House Bill 1959, that was introduced by Senator Bobby Harshbarger on the Senate side and Representative Rick Scarborough on the House side. Basically said that. Now, the approach that it was taking was that it stated that as the Board of Pharmacy, who licenses pharmacies, they would have the jurisdiction to say, we can license this pharmacy or not, and they'd have to prove who their ownership structure is. And so the bill basically said you cannot be a health insurance issuer and a pharmacy benefit manager and own your pharmacy. So it had to have that stipulation of being a health insurance industry or issuer and a PBM, which again is where we started seeing this vertical integration from the insurance company to the PBM all the way down to the pharmacies and the problems that ensued from there.
Putting a bow on FairRx, how does FairRx help keep drug costs in check?
Yeah, it's a good question. I think a lot of it comes down to access. What FairRx is aiming to do is really ensuring that where the patient wants to get their medicine from is convenient and accessible. I think we've seen certain of these other avenues where products are being dispensed from are either delaying care and adding costs into the system, or adding to problems with waste in the system, whether it's from a mail order pharmacy or other avenues like that. So to me, FairRx is kind of to the point, I think, of where the name came from, is providing a fair platform for any pharmacy that wants to be able to participate and provide care is eligible if they want to agree to, say, the same terms and contracts of what the insurance company is laying out. back in 2021 and actually 2022 with some clarity in legislation. What pharmacies were able to negotiate and work through at the state level is to say that pharmacies should be paid at cost. Now, pharmacies can always, there's a mechanism through the PBMs to appeal a drug reimbursement price. Many times that process would get denied in many cases. What the legislation in 21 and 22 really said is that no, a pharmacy must be paid at the cost of what they're purchasing the product at. Now, that doesn't necessarily guarantee they're going to make anything off it, but at least they'll get paid at cost of what they're doing. Now, they got to submit all those invoices and everything, but there is a mechanism in the state of Tennessee to do that. Not every state has that.
Do PBMs offer different contract rates to different pharmacies for the exact same drug?
Oh, yeah. Yeah, definitely. I mean, for various reasons and
volume,
negotiations
size,
and rebates and market penetration. I mean, there's a lot of different things that they're using to negotiate that down. But I think at the same time, what we consistently hear, at least at the association, is that many pharmacies, even the larger pharmacy groups, do not have negotiating power in that contract negotiation. It's many times a take or leave it contract. And it seems like each year the PBMs just keep cutting reimbursement. It's never giving money back or raising reimbursement. They just keep finding ways to cut the reimbursement.
The lawyer in me screams, why not ask? Why not?
Oh, they do. They do. And whether you're a large chain, I mean, I think there's been some more public fights in this area. I think probably some of the recent ones that come to mind, I know our friends at Kroger, the grocery chain, have had their own bigger beef with one of the bigger PBMs, Express Scripts, and they actually said, we can't take it. We tried to negotiate a contract and we couldn't. I believe a couple of years back, Walgreens had a very similar debate with TRICARE, the federal plan for our veterans, as well as Express Scripts, that PBM that they contract with, and Walgreens couldn't come to a consensus either. So they try, and so it is a struggle now. For the bigger chains, they can do some of that in-house. There's a whole nother area in the industry that helps groups of independent pharmacies or smaller chains try to do that contract negotiation. Those entities are called Pharmacy Services Administrative Organizations, or PSAOs. And so they try to leverage groups of independent pharmacies or smaller chains to do the same thing. But it's still, we consistently hear in the industry that it's a take it or leave it contract.
Got it. Do the PSAOs offer that same type of negative reimbursement exchange? Do you still see that in that space?
Yeah, you do. And I know from some of the members that we hear from, even their PSAOs are like, you don't want this contract. And so even some of the PSAOs are like, no, we did not sign that contract on behalf of all of our pharmacies that we work with. So even they struggle, right? So, and I think that's the ongoing, just like it blows people's minds that there's no ability to negotiate and get fair reimbursement. And that's why I think it comes down to legislative action ultimately, to make sure that pharmacies are seeing at least a fair reimbursement.
It feels like otherwise judge, jury, and executioner are making all the rules at the same time.
Or the fox guard in the hen house, or however you want, whatever analogy you want to use.
Yeah. It's difficult when one person holds all the cards.
Mm-hmm.
It's difficult to make the playing field fair.
Right.
And ultimately, at the end of the day, the job in healthcare is to deliver a therapeutic remedy to a patient.
Right.
And that's needs to be top of mind.
Right. There's a saying I've always had in my training that if it's right for the patient, it's right for the profession. And so we're ultimately trying to do what's best for that patient, however they want to get their medication, but we ultimately want to make sure that they're using it correctly and at effective dosing, being properly monitored, because that's what medicines are doing. I mean,
sure.
we know they're going to help improve health outcomes when they're taken appropriately, and we firmly believe pharmacists play an essential role in making sure that outcome is positive.
What would you say somebody just walked out of pharmacy school that wants to open their own pharmacy, top 3 things they should be on the lookout for, pitfalls, concerns?
Yeah, if they want to get into pharmacy, and if you're saying to be an independent
practice,
independent practice, there's a lot of tools out there. Some of our national associations have some really great training workshops on what it takes to go into ownership. I do think there has to be a business mindset, right? Because you're owning your own business, you're taking out loans, and that's assuming you're starting from scratch, right? But some pharmacies, there's a lot of different models for a young practitioner to look at. They can go into junior partnerships and other things like that. So I think you definitely need to think. You have to have that business mindset. Not saying you have to all go in and get an MBA, but I think having a little bit of business background goes a long way. I do think at the same time, you have to have an entrepreneurial mindset and thinking about it in a clinical lens, right? So what are the needs of your community? What kind of services can you offer that maybe augment maybe a lot of those losses on the product dispensing? So, a lot of times I'll tell a new practitioner, have you connected with the local providers in that area? Or have you talked to the local health department? Because there's services being offered right now, but there's also some gaps, or there's just limited resources. So you as a pharmacist, you're coming out with this massive amount of knowledge. What can you do to use that to be the best provider for your community? Hey, you might really care about diabetes and you want to do some great stuff in diabetes, but you know what? There might be a ton of diabetes care providers in your community. That's not what your community needs. So what do they need out of you?
Yeah.
So be vigilant of what is most of need, and think about it from that pharmacy landscape. So yeah, I think that entrepreneurial clinical mindset is very important to augment that business mindset.
You have to know your practice inside and out. Your record keeping apparatus, your security controls, your employees. You can only have a certain type of employee that touches controlled substances. Mm-hmm. You have to know the practice front, backwards, and sideways. Right. Ignorance is not an excuse.
Right.
And it's unfortunate during my time as a regulator, to talk to somebody that said I had no idea that was the case is a tough conversation to have. It doesn't excuse
any business owner. You're managing people in the end. I mean, that's first and foremost.
Yeah.
If you got the right team around you, wherever you are, whether you're a healthcare team or if you're at a business, whatever it is, your team makes and breaks you. So you gotta treat your people right, so they can ultimately, in this case, take care of the patients of your community.
Let's end with this. As I came to private practice, one of the tools that I'm so fortunate and blessed to get to utilize now is artificial intelligence. And I was scared to death of it when I walked out of a very rigid system into the capability of what artificial intelligence offers. I heard somebody say in a seminar that AI is not going to replace lawyers. AI is going to replace lawyers that don't use AI. And I thought that was very profound. I turn the question to you. Where are we headed in that space in the pharmacy?
I actually like your analogy because I do think it's the same thing in pharmacy, right? One of my biggest things that I tell people is, if probably the biggest pain point that I see in some pharmacists is apathy, period, right? They want to stay in the model that they're used to, and we all kind of want to have that comfort, right? But I think one of the only constant things these days is change in society and in healthcare especially. And so to your point on AI, I think we are seeing pharmacies and clinics and other practice settings with pharmacists using AI to better enhance that experience. You may have come across in your research and understanding around the Institute of Medicine that talks about the triple aim, right? When we're talking about proper cost of care, better experience, and a reduced cost. Well, we also talk about the quadruple aim and how are we helping practitioners be the best practitioners for their patients. And so I actually really like some of the examples I've seen is where AI is really helping augment some of the documentation that might be like listening to a conversation that you're having and helping a pharmacist dictate their notes, or they're doing this in physician practices. Documentation
yes.
It's the bane of all of our existence
yes.
at times, but if you didn't document it, you didn't do it.
Yeah.
So if AI can help augment some of that and enhance that experience, so pharmacists in this case can have more time with the patient and let AI help them dictate their notes, I think that would be an amazing tool. Medications continue to get more and more complex. And I do think we are eventually going to move into a healthcare system that is much more personalized and thinking about the genome. That's a ton of data. And how do we maybe utilize AI to take some of these very complex things and get it down into a format that a pharmacist can utilize to make the best therapeutic changes for that patient, and then communicate that to that patient or to a provider, whomever. I do think there's some really great uses when it's done the right way. I mean, there's still a lot of unknowns, I think, on how well AI is being utilized, but I do think we're going to need it. I mean, there's so much information, so much clinical information, so many clinical trials coming out, and new information and guideline changes that are going to have to come forward, that I do think AI can really help that clinical side of it. But to your point, you got to make sure you're using it and use it well, because it's happening and it's going to happen.
I don't think it replaces people yet, at least in my line of work. I was telling somebody the other day, I asked AI to read copious amounts of material, and it did it quickly. It's still got all the citations wrong inside its closed universe. And so it's not foolproof, and it's not fail-proof, but it's certainly a tool.
Yeah, and let's talk again in like maybe 3 years, because I'm sure it'll be continually evolving, right?
3 months. Thank you so much for coming.
Of course.
Thank you for joining. Fascinating discussion. Look forward to doing this again sometime.
Yeah, fantastic. I appreciate the invitation. Looking forward to further conversation.